Hello, everyone. Welcome to the NTI PodTalk. My name is Dianne Kaler, and I'm the Director of Nutrition Therapy Institute. This PodTalk is our opportunity to have fun conversations with interesting people who have interesting things to say about nutrition, food, and health. I talk to NTI instructors, students and grads, to health industry professionals, to farmers, and anyone else who has an interest in nutritional wellness. While many of our listeners come from within the NTI community as students and grads, we also have prospective students who tune in. And to those listeners in particular, I hope you find that the people we talk to inspire you to finally make the jump to pursue your passion and come to school here at NTI. So without further ado, let's get on with the show. Hello there. Welcome back to another edition of the NTI PodTalk. My name is Dianne Kaler, and I'm the Director of Nutrition Therapy Institute. We have so many fun conversations on this PodTalk, and today I think we're in for another one of these fun conversations. Today we have Dr. Abby Bleistein, who is I believe owner, certainly director of the Healthful Life MD clinic, which is a medical weight loss clinic in Golden, Colorado. So we're going to be talking about a topic that many nutrition therapists are interested in, because many of our clients come to us in terms, for help with weight loss. And so I think it's really helpful to get your perspective from a medical doctor perspective. So with that said, Dr. Abby, thank you so much for being here. I'm really excited to our conversation.
Well, thank you so much for having me. It's great to be here. I'm happy to talk with you.
Yeah. So if you could just start off by giving us your background. What's your educational and medical background, so we kind of have an idea of where you're coming from?
Yeah, so I am a physician. I'm board certified in internal medicine, pediatrics. I'm also actually board certified in obesity medicine. So I actually specialize in this area. Mm-hmm. And I practiced primary care for about 17 years before I transitioned into doing primarily obesity medicine in practice. Mm-hmm. So yeah.
Well, so I want to talk about two things. First of all, I want to talk about medical weight loss and what that means, because as I said in my introduction, your clinic is a medical weight loss clinic. But then also, what was your interest? How you had obviously lots of opportunities to do all kinds of things with your medical career. What drew you to this field for weight loss?
Yeah, it's a great question. In practicing primary care, there sort of came a point where practice itself was kind of untenable. There was almost a values mismatch in terms of how I wanted to work with patients and treat patients and what the system was requiring me to do. So that sort of triggered me to start to look into other things. But the other thing that I was noticing in practice is there were a bunch of diseases that I sort of consider diseases of nutrition, if you will. And so we think about
I love that. I love that concept.
Yeah, because the reality is that, things like non-alcoholic fatty liver disease. And so I was seeing these patients who, and maybe they didn't even carry extra weight, and they had liver disease, which is, really based on nutrition, what you're eating. Diseases like metabolic syndrome, insulin resistance, and overt diabetes, high cholesterol, hypertension, reflux, all of these things that really could be changed significantly with improved nutrition and improved fitness. Mm-hmm. And so that idea of metabolic disease and really helping people work on those things from a more holistic approach really became exciting to me. And I actually went to the Obesity Medicine Association, does a board review course every year, as well as a scientific conference. And so I went to that board review course, and it was kind of like the first time I was really excited about the science of medicine in a while. It was just lots about nutrition, lots about fitness, but also, metabolic disease and how did these things tie in, and behavior and psychology of these things. And it was just very exciting to me. And so I, brought it back to practice and found that I could really make a difference in people's lives by incorporating this sort of more holistic approach.
Wow, that is awesome.
Yeah.
And it's awesome to hear you say, that this is a holistic approach. So let's talk about what is medical weight loss, and then kind of what is your more holistic approach to weight loss.
Yeah. And so really, when we think about the term medical weight loss,
Yeah.
it really means weight loss that involves a physician, right? And so sometimes that could be a medical team. Sometimes it's just the physician themselves. Oftentimes it may involve medication. And I think we probably would put bariatric surgery, in that category of kind of medical weight loss. But it can really range in what that means, right? It could just be a doctor who's sort of practicing this by themselves, or it could be a multi-specialty, approach or a team approach. But it really, medical weight loss itself just means that, that a physician is involved. As I said, I'm board certified in obesity medicine. So there are a number of physicians now across the country who are actually engaging in the, really learning the scientific research and data, and how do we really best approach the disease of obesity to really help these patients. And so, so that would be a whole, other level of commitment from these physicians. And for myself, as I left primary care to try and see, what can I do with this? The reality is, as I was seeing patients, a lot of times I would feel like, I know some about nutrition, right? I researched it. I know something about nutrition. I know something about exercise. I certainly know a lot about metabolic health and disease. But I would get to a point sometimes where patients where I'd say, I think a nutritionist or a dietitian would really be helpful for you. And they would say, is it covered by insurance? And I would say no. And so oftentimes I couldn't really get that additional support that I felt patients needed. And so I thought, if I'm going to design a practice that's really going to help patients with sustainable lifestyle change, how do I help patients get healthy and live their best lives in a way that they can sustain, lifelong? What's the best way to do that? And the reality is we don't have the magic to that, right? We don't know how to do that to help people. But I thought, how would I design that program if I were going to do it? And so that's really what I've done with my program is I feel like a multidisciplinary approach with specialists in the areas, of obesity is going to give patients those best results. And so we think about obesity, it's a multifactorial disease. There's lots of things that lead to obesity in patients. And so, medically, I can help patients with metabolic disease, with medications and other things. But I also have a dietitian and a nutritionist that work with patients. I have a trainer who specializes in, not just training, but she's worked a lot in rehab. So helping patients who may have chronic pain issues or other things like that really get back to exercise. I have health psychologists, one who specializes in eating disorders and trauma and mood disorders, and the other one actually specializes in sleep problems and chronic medical conditions. We have a chef that helps people with culinary nutrition to really help people learn to cook and eat real food. So it's a comprehensive approach with a lot of specialists so that we can address each of the aspects of kind of the multifactorial disease of obesity.
Yeah, that is fascinating. I mean, it definitely is very much of a holistic approach. And what I'm curious about is, you say that you specialize in obesity medicine, you're board certified in obesity medicine, but do other doctors who are board certified in obesity medicine, do they also take this a holistic approach? Is that the training that you receive in your training for obesity medicine? Is it this holistic approach, or is it just drugs and bariatric surgery?
Yeah, so I would say physicians that become board certified in obesity medicine are really looking at the more holistic vision of treatment for obesity, that it is a multifactorial disease. So if somebody actually has that board certification, I do think that suggests that they really are interested in the disease of obesity and optimal treatment for it. I would say that I think it's unusual to have a practice that has, dietitians and trainers and, everyone under one roof. Some physicians will do all of that on their own. Some physicians may have a dietitian or they may have a trainer. So it really varies from practice to practice. But I would say that the board certification, those docs really get an understanding, and the board, the board exam and all of the education really is around this multifactorial, or this, they call it the pillars of obesity. So we can really explore all these different aspects to help support patients.
Well, I will be really honest. I am surprised to hear that. And I'm glad to hear that, but I'm surprised to hear that, because my perception from sort of, my perception of a very conventional view of weight loss is around, the energy equation, calories in and calories out. And as long as they balance, then everything is fine. And that's my impression of how the conventional medicine view looks at weight loss. And therefore my interpretation is that to be board certified in obesity medicine, you are still using that as the foundation of the understanding, and therefore bariatric surgery and medication is kind of the end result of everything that you do. Because if all you can tell people is watch what you eat, count your calories, and then make sure that you exercise to compensate for that calorie intake, everything is fine. And if you still have a problem with overweight and obesity, then the only thing we can do is drugs or surgery. And so my perception is very limited. And so thank you for opening my eyes. But I do think there is still this energy balance equation that is what we hear and what we talk about. I don't think my perception is different than what most people's would be. So can you talk about that?
Yes. And so it's interesting, because I think your perception is probably accurate, that, the average patient going in to see their average doctor, the primary care doctor is going to say, and the doc may say something like, oh, I think you need to lose weight. And patient will say, yeah, because it's like rolling your eyes, right? Like, I'm trying, I understand that.
No kidding.
It's not working, right? And I think physicians are like, just eat less. Why can't you just eat less? Right? Well, there's a lot more to it than that. And so, and I think, for a while, I think there were debates, about, calories in, calories out versus macros, and what kind of calories and what kind of food. I think that debate is, within obesity medicine itself, is really shifting, where it's very clear that the kind of calories you eat matter, and not just matter for weight loss, but matter for health. Right. And so when we're talking about, and like I said, we're talking about metabolic disease, you don't need to carry extra weight to have metabolic disease. Right?
That's right.
I've seen patients with fatty liver with insulin resistance, even with type 2 diabetes, who don't carry significant extra weight. And, so if we look at it, about 80% of patients who carry extra weight have some kind of metabolic dysfunction going on. But the reality is about 40% of patients who are where we would consider, at a normal weight, also have metabolic disease, right? And so what you're eating really does matter, and not just for your weight, but also for your health. But we also know that anything that's going to raise your insulin significantly is going to lead to, weight gain. Right. And so if we're eating things, lots of processed foods, and in particular sugar, that's going to lead to weight gain. And so eating 500 calories of sugar may help you lose weight, but you're not going to be healthy at the end of it. Right.
Right.
And my goal is always, I need you to be healthier at the end of the process than you were at the beginning. And you're not going to be healthier if you're not really paying attention to what you're eating. And the reality is the types of calories that you're eating. If you're eating stuff that raises that insulin resistance, it's going to be much harder, raises insulin, sorry, it's going to be much harder to lose weight, with those kinds of foods. And I think it's pretty clear that highly processed foods really are wreaking havoc, on our bodies, and sugar in particular is really wreaking havoc on our bodies. And it's leading to weight gain, but it's leading also to metabolic dysfunction and disruption in our hunger satiety circuits that ends up kind of snowballing. And so, yes, a calorie is not a calorie. I think it really matters what you're eating.
Yeah. So I'm curious, when you're doing assessment of metabolic disease, are you testing insulin levels or are you testing blood sugar levels? What do you use in your practice?
So I use a number of different tools, right? So we know as we're looking at kind of the process of insulin resistance, the first thing that actually changes is your cholesterol. Right. And so the dysfunction that's happening in your liver that's leading to insulin resistance really affects your lipid panel first. And so we end up seeing hypertriglyceridemia, high triglycerides, and low HDL at the beginning of insulin resistance. And so if I had a patient who, who came in, they may have a normal hemoglobin A1C and they may even have normal blood sugars, but then their triglycerides are 3 times, or more the HDL level. If I checked their insulin level, a fasting insulin level, it's going to be high. Right. So they're going to have insulin resistance. And so really the earliest sign of insulin resistance is going to be some of those cholesterol changes. And then you start to see the hyperglycemia, and then you start to see the change in the hemoglobin A1C. So I check all of those numbers. Fasting insulin sometimes is covered by insurance, sometimes not. And so I try to make it affordable for patients. But if I really suspect, and particularly in my younger patients and kids, because they're not going to have some of those other changes. We'll see those cholesterol changes. We're not necessarily going to see that elevated hemoglobin A1C yet, but I had a patient whose hemoglobin A1C, I think it was 5.2, 5.3, which is in the normal range, for the people watching. And her fasting insulin was 90, which is sky high. So just as a... So as an example, right? So that was really useful information because, her parents would look at that and say, well, she's fine. Her hemoglobin A1C is 5.2. And it's like, well, no, she really has significant insulin resistance that we have to address with changing her nutrition patterns.
Yeah.
And exercise, right? Exercise.
Right. Yeah. Yeah. All right. So just to clarify, are you saying that the triglyceride to HDL ratio is a proxy for a fasting insulin, for a fasting insulin? I mean, yes, for a fasting insulin test. Like, can you say that anyone who has a disruption in their, or, elevation in their triglyceride to HDL ratio will have a high fasting insulin? Is that what you said?
Yeah. So if you have a patient, and not necessarily the high fasting, they're going to have insulin resistance. So if a patient's triglycerides are 2.5 times their HDL, they are very likely to have insulin resistance. And certainly if it's above 3, it has to be fasting, right? So fasting cholesterol, fasting lipid panel. If you see that, it's very likely that they have insulin resistance. And, and the caveat to that would be there are some situations of familial hypertriglyceridemia where patients might be overabsorbers, hyperabsorbers or overproducing, where it's not necessarily insulin resistance. It's an enzyme disruption that's inherited, and so those things. So there are caveats to it, but yes, in general, if you look at that lipid panel and you see that, it really is an indicator that there's some insulin resistance going on.
Yeah. So then I'm stuck on this. I'm sorry. Then vice versa, it would be impossible for someone to have a high fasting insulin level and not also have high triglycerides to low HDL ratio. Is that also true?
I think it would be unlikely.
Okay.
But the caveat to that again would be if you have, one of these heritable, hypertriglyceridemia or cholesterol issues, where it's really a problem of the enzymes, of the absorption of something else in the process, where it may not necessarily be that they're insulin resistant.
Okay.
Yeah.
Okay.
Yeah.
All right.
So hopefully that's helpful. Nothing is absolute, but
well, yeah, and I'm using these very absolute terms, but and I guess the reason why I'm asking is because I've heard so many people talk about how you cannot for certain understand someone's sort of insulin resistance and I'm talking about before someone gets a diagnosis of insulin resistance. You can't really understand what's going on with their metabolic health, I should say, without knowing what their fasting insulin level is. And as you rightly say, fasting insulin levels are challenging. It's usually not covered by insurance. Most conventional medicine doctors wouldn't approve ordering it unless they had some sort of, really convincing reason why they think they should order it. But because there's nothing that they have in their training to understand what that means to have a high fasting insulin level, right? And so
Well, but and the other thing,
it's challenging to make the case that you have to do this test that is difficult to do, difficult to pay for, when there is a good proxy for it. So that's where I'm coming from, just trying to clarify.
Absolutely. But the other thing is, you could make the case that would the fasting insulin change management? Right. And the reality is, if someone carries extra weight, the likelihood that there is some portion of insulin resistance there is, pretty high, and it's not going to change too much about how I'm going to change their nutrition and really work with them. So I tend to use it more in the case where patients might be resistant, or they might not recognize it, or if it's not clear, right? So, hey, you have triglycerides of 500, you probably have familial hypertriglyceridemia, but let's look and see, do you also have insulin resistance, right? So then I might order it in that case. So I was, it's one of the tests I don't order consistently.
Gotcha.
I can use, we can use something called a HOMA IR, which looks at the sugar and the fasting insulin at the same time. So you can do a calculation that may approximate the level of insulin resistance, but it's not perfect, right? So, so none of these tests are really perfect in that way. So they're all signs, but they're helpful in the sense that you look at them and go, you likely have insulin resistance. But I do think that the cholesterol panel can be a really helpful tool for people, because the reality is, if you see that, that the patient has insulin resistance, or very likely does, and that you should be treating them in that way. And you can share that with them. Hey, you're leading in this path that's not going to be good for your health long term, right?
Yeah. Okay, that's very good. Thank you for explaining that. Two other things that I want to come back to is, I love how you talk about that the end goal is improving someone's overall health. It's not necessarily how many pounds did you lose and were you able to keep it off. It's how healthy are you? Because the more healthy you are, the more likely you are to sort of just naturally lose weight and be able to make it easier for it to stay off. Correct? Am I correct in that?
I think there's so much that causes weight gain, and there's also a lot, there's a lot that goes into what a person's weight is, and where they end up maintaining or settling, regardless of, how healthy they're eating or whatever, right? So I would say that, I don't think that's exactly correct. But the reality is, a lot of patients come to me and they say, what weight should I be? How much do I need to lose?
Right.
And it's not, to my mind, there isn't a number, right? There's not a number that you need to get to. So to my mind, I think the goal is, and what I tell patients is, I don't know how fast this process is going to happen. I promise you, every week you're going to feel better and better, right? Because as you're getting more healthy, you're eating better and you're exercising, all those things, you're going to feel better. But at some point, what's going to happen is your numbers are going to improve, right? You're going to look metabolically healthy in terms of labs. You're going to be able to do the activities that you enjoy. You're going to have decreased, problems in terms of medical issues, right? Let's hope the diabetes goes away. Your hypertension is improved. Your pain is decreased, and all of these things, you're sleeping better, all of these things will happen. And at some point you'll say, you know what, this is sustainable. I feel great. I can do the things I want to do. And that's when we're done. Right. It doesn't have to be that you're at a certain weight or a certain BMI or anything. It really is about, what's going to be sustainable, and are you healthy, when you get there. And so those are the things that I think are more relevant, because really what we're talking about is your overall health, and, how are you living your life? Are you thriving? And that's what's most important, I think.
Yeah, absolutely.
Mhm.
The other thing I wanted to ask, you were mentioning about a patient that you had where hemoglobin A1C was normal, great, in a great range, and the parents were, from what you said, sounded to be resistant to the fact that she needed to make dietary changes to address insulin resistance. Do you find that your patients are resistant to making dietary changes? Like do they think that there's an easy way around this? Like, can they just like, or do they come in like being fully prepared? I'm going to have to make dietary changes. I'm okay with it. And I'm going to just jump on board this train and make whatever dietary changes the doctor says. Like, how easy is it to get them to that point?
What does that look like? Yeah. And so it's interesting. So I think that patients kind of self-select for their treatment. And so for my patient population in general, those patients feel like what they need to do is change their diet if they want to lose weight, right? So most of my patients coming in with the expectation that they need to change their diet. I struggle more in my practice, in particular, just with helping patients get into a regular habit of exercise, right? But what's interesting is when I talk to my colleagues who are trainers, what they say is, yeah, my patients exercise all day long, but they will not change their diet. I can't get them to change their diet. And so the patients who feel that exercise is key go to a trainer, and they're a little more resistant to those nutritional changes, whereas patients who come to me have an expectation that, yeah, I probably have to change my nutrition. Now, that being said, those changes are hard, right?
Yeah.
For a number of reasons, it's really hard. And so whether it has to do with the hunger satiety circuit, in the brain, or even, when we carry extra weight, right? The fat that we're storing is not just a depot, right? It's not just storing fat, but the reality is that adipose is an endocrine organ.
Yep.
Right. And the adipose is sending signals to our brain about whether we're full or whether we're hungry, whether we have enough nutrition or need more. And for some patients, when you have the cells, there are two ways that adiposity can develop. Here, I'm going to get geeky science so you can stop me so much. So the two ways that adiposity can develop is either you make lots more fat cells, right? So you have smaller, but lots of them, or you end up kind of overstuffing the fat cells that you have. And the patients who get metabolic disease are getting overstuffed fat cells, right? And so it's the overstuffed fat cells, that the hypertrophy of the fat cells that ends up disrupting the function of it. And those signals about hunger and satiety really get disturbed. And so a patient, may be completely nourished, but feel hungry anyway, right? So they could be starving, and so patients will tell me that, like, I feel hungry all the time because the signals are disrupted and they're not, the signals are not saying the right thing, right? And so really how patients, gain weight or lose weight, and how they make those nutritional changes, it's really hard to make nutritional changes if you're feeling hungry all the time. And, even though we might address those macros, we'll increase protein, we'll increase fiber, we'll get those healthy fats going to help with that hunger, it takes a little bit before those signals start to get strained out, right? And so it's there's more to the picture than just, we just make these changes and it all happens. That's not the case for everybody, right?
Yeah. Well, so you talked about, your holistic approach and the various types of practitioners and, professionals that work in your clinic, and you have an NTI grad, so a graduate of NTI on your staff.
I do.
Which, we're always proud to talk about the fact that we've got our grads working in these, with these very high profile sort of high impact clinics. And
yeah,
so
exciting areas of medicine, right? Yeah.
Yeah. So very excited about that. So what services does she provide for your patients? What made you want to hire a nutrition therapist in particular in your practice?
Yeah. And so, really the training for nutritional therapy is really, I think, a very holistic approach about the interaction of nutrition, with a person's, body and metabolism. And so it's really looking at all of those things together. And so I find that really important, for our patients to understand some of those things. And so, Erica's just been fabulous, and I've learned so much from her, which is, it's really interesting. But the training, I think what it does is it really helps her to understand, a constellation of symptoms, how food might be impacting, and either exacerbating those symptoms or actually causing those symptoms, for a patient. And so, with the foundation, I think that she added NTI, and then, and what she would say is, this really strong foundation where she can go on then for lifelong learning to really explore these fields in more depth as things change and such. But really what she's able to do is take a patient's constellation of symptoms and say, I think we need to cut out these certain food groups and see if the patient doesn't feel better, right? Or I think this looks like a vitamin deficiency or something. And she also is a certified gluten specialist. And so I have patients who seem to have a gluten sensitivity or may have celiac and have been tested. And, and so we can order the tests, and then she can really help to hone the patient's or fine tune the patient's nutrition plan so that it really is optimized for them and to decrease their symptoms that have been really, bothering them. So, and Erica also is specialized. She can interpret SNPs. And so we've done some of that kind of testing, or if patients, do some of the genetic testing that she can get publicly. She can actually go back and look at the raw data of those and look at the genetic SNPs that may make it difficult for patients. So for example, I had a patient who was having some chronic pain issues and some ongoing problems with fatigue, and no one could quite figure out what was going on. And she had a SNP that she was a poor absorber for vitamin D. And we said, we got to put her on high doses of vitamin D to actually get it to absorb and get her levels up. And within a couple of weeks of high dose vitamin D, her symptoms that she'd had for years just went away. I mean, it was just this dramatic, life-changing kind of thing. And then we could start to decrease, but we knew, we know that, wow, for this patient, we're always going to have a higher dose than what we might consider for other patients. And so she really helps me, to understand those things. So that functional nutrition piece, I think, is really helpful for my patients to make progress, but just to feel better, right?
Right.
Well,
right. Yeah. It's I always get, talk about geeking out. I always geek out on how often a simple nutrient deficiency causes problems that people have attributed to all kinds of these big diseases and big, really complex problems. And then suddenly it's just, you've got a simple nutrient deficiency, and you just need to, either eat more of the foods that contain it, or take higher, take a supplement to compensate for that deficiency. And, it seems like magic. But it's not. It's like nutrients, nutrients play roles. Like nutrients have an impact, right? Your
That's
food
exactly
matters.
Right.
Nutrients truly do impact the way your cells function, the way your body functions, and these simple nutrient deficiencies, as long as you can figure out what they are, it's like,
it can be amazing. Yeah.
Wouldn't it have been nice to like make that the first thing we look at
The
rather
first
than
thing
the
we check.
last?
Yeah, yeah. And it's
Yeah.
really, yeah. And I love how you say, oh, it's like magic. Because I say that sometimes like, it's magic. That's incredible. Like these changes. And then, and then of course my colleagues say, no, it's science,
Yeah.
yeah, you're right. Yeah. But
Sure.
it really is, it's incredible for patients who have been really struggling for a long time. And I'm sure I'm sure your listeners have experienced this themselves as well. Patients who've really been struggling for a long time, and to have that kind of improvement in their life, it's just, that it's an incredible thing. It really is amazing to see. Yeah. So, something to look forward to for those students and stuff. It's such a great, and I love what I do because I love seeing people really thrive and feel good, energy improve, all this stuff. It's just fun. It's fun medicine.
Yeah. Well, there's one question that I forgot to ask you earlier that I want to come back to. We were talking about in the context of medical weight loss, and there are medications, right? There are drugs that are used in weight loss. And I think sometimes people assume that the drugs, speaking of magic, that the drugs are magic pills and that all you have to do is take a drug and all of your problems will be solved. Can you sort of disabuse us of that concept and kind of talk about like, I don't know a lot about it, but apparently there is one type of drug that all the celebrities are using, and
some of the newer drugs, sure.
Yeah, and it's kind of a not so inside trick that they're using, and inside joke and all this kind of stuff. So can you talk about that from that medical medicine standpoint?
Yeah. And so, what I think is important to recognize when we talk about obesity as a multifactorial disease, right? Every person is a little bit different. And that's why I practice very individualized care, right? Everybody needs something a little bit different, and what's affecting them is a little bit different. And the reality is we actually have studies that show that to be true. And so there's a really interesting study that looked at phenotyping obesity. And so patients with obesity may have certain aspects that are more prominent and as a role, in the disease course. And so, there are some patients who have, say, a slower metabolism than average, or there are some patients who have decreased satiation, meaning that, when they eat, they get hungry sooner than you might expect them, or than the average person might be. There are other patients who have decreased satiety, meaning they don't recognize fullness. Right. And so they eat, they don't recognize fullness. And there are some patients as well who maybe are prone to what we call hedonic eating, or this emotional eating circuit, or even, kind of binge eating disorder, for example. And so I think there's a role for medications to play. And the study that I'm describing, when they phenotyped patients and decided what's really prominent for you, if they chose medication specifically for that issue, they lost more than double the weight on the same program. Right? Twice as much weight loss. So patients who just were on medication versus patients who were phenotyped and put on the same medications, the patients phenotyped who were on a specific medication did better than patients just randomized to medication and treated with nutritional plan. So, and so what the study shows us is that medications do have an impact and can make a big difference for patients, but they don't work in isolation. So as a physician, if I hand a patient medication and say, just eat less and go away, they're not going to be as successful as if I hand them a medication and then I help them with those nutritional changes. And so really, medication is an adjunct to treatment where it helps patients make those nutritional changes that are going to help keep them healthy lifelong. right? And so it really helps with that hunger satiety circuit. These medications have been shown to affect food choice. So it helps patients when they're sitting in front of a buffet to say, I really want the salmon with the asparagus instead of, that big plate of pasta and the brownies, right? And so medications actually impact that food choice as well, but they're not in themselves, doing, they don't do all the work themselves, right?
Gotcha.
So that's kind of how I think about medications. It's really an adjunct for treatment. And if we refine how we're treating, we're going to help our patients be far more successful and have better outcomes. The newer medications, right? So what we call highly effective anti-obesity medications. And these are actually gut hormones. So the most prominent one that you're talking about and hearing about right now is semaglutide, which is a GLP-1 receptor agonist for those who are interested. That's what it is. And it's a gut hormone. So what it does in the gut is it decreases the rate of gastric emptying. So it slows gastric emptying. You feel full longer. You actually are full longer, right? And so it helps in that way, and patients really feel very full. What's interesting, though, is there are receptors for GLP-1 in the brain, and they're both in that hunger satiety circuit. There are receptors in the hedonic eating centers of the brain for GLP-1 as well. And so I think the reason that GLP-1s have been so effective is that they're actually hitting kind of three different aspects of hunger and satiety and why we eat all at the same time. And so that's why these have been really effective. But we can't use them in isolation. And so, so for example, I work at the Eating Recovery Center. I do coverage for the medical teams there on occasion. And what they're seeing with these medications is that there are some patients who are really treated inappropriately with these medications, or they're not followed appropriately. And it can be really dangerous if you're not following or treating the nutrition with these patients. And so they had one patient recently who actually had a long time struggle with anorexia, and she was up to a BMI of 26, and her doc put her on one of these highly effective anti-obesity medications. And it really, it's, to my mind, it's really a contraindication to use a medication like that in someone with a history of anorexia, because that's a chronic disease process that may go in remission, but I don't know that it ever goes away. I think you have to be really cautious with that. And the patient actually lost down to a BMI of, I think, 18 or 16 before she was hospitalized on the medication. I mean, it's just really scary because, it just sort of helped her, that disease voice, the anorexia voice became very loud, and she had this additional assistance in not being hungry. And so really scary. And another patient who was seeking weight loss, looking to get bariatric surgery. His weight was around 600 pounds, I think, when he started. And the goal of his doc was to get him down below 400 pounds. And he lost more than 40 pounds over the course of a month, so it's, close to, it's not quite to 10%, maybe 7% weight loss in the course of a month. And it's just really, and basically she kept titrating the dose up till his appetite went to zero, which is, there's no reason to do that. And his weight loss was precipitous, and he was hospitalized for malnutrition, from that. And so I think, the medications themselves are very helpful, but they should not be just given in isolation, and there shouldn't be an expectation that you can give it and leave patients and not watch them or not use, medical sense, right? There's some medical common sense that you really need to look at the patient and see. But that being said, these GLP-1s can be really life-changing for patients. So, I haven't found that I've had to titrate the dose to the maximum dose in anyone. Most patients actually do very well on some of the lower doses, where it's sort of that constant food chatter, right, goes away, but they have a regular appetite. And so what I hear patients say is, I can eat a meal, and I recognize when I'm done, and there might be food left over. I've never had that. I've never recognized fullness during a meal in my life. And now I can do that. And it's just this amazing thing. Or I don't, I can go grocery shopping and I'm not thinking about food all the time. And it's just life-changing. And so you can imagine just the mental energy involved in that constant food chatter and hunger, and not feeling sated and stuff, and to have that change, it really helps them. And what it does, is it helps them make those nutritional changes that are going to get them healthy, right? So the medication alone doesn't do it, but then they can look at a plate of food and decide I'm done, or they can look at a buffet and decide, I think I want to eat that instead of this. And it brings it all to the frontal lobe where they can actually think about it instead of this sort of urgency. And, it's hard to describe, patients experience it differently, but sort of this urgency around eating and hunger that really is improved with medication. So that's a long-winded answer, but
yeah, no, it's good because, in your practice, you're trying to get them to understand the importance of their nutrition and making different choices. And so you don't want them to be at a point where their appetite is so low that they don't want to eat the nutrient dense foods that you're trying to encourage them to eat.
Yeah. Because you can. I mean, with the newer medications, you can get to the point where their appetite is just zero. And that's not our goal, right? That's not our goal, but our goal is to take away that, that voice. And then you can start to really think about food in a more intuitive way. It allows you to be more intuitive about what you're eating, and it allows you to incorporate your values around it, right? So people recognize that, I feel better when I eat in this way, right? I feel better. And it helps them to make those choices that they know are going to help them to feel better long-term. So, that's exactly.
That's great. That's great. So, I know that there are probably many ways in which you work with your patients, in your work to personalize and tailor your protocols for your patients. You're probably doing lots of different things, but are there one or two general nutrition guidelines that all patients get, these are the baseline things that you must do, must think about, no matter how much we tailor all the other stuff, here are some basic foundational guidelines.
Yeah. So I think the biggest thing, from where I come from philosophically, I worry about sugar. I think we eat too much sugar. There's too much added sugar in our food. And I think really working towards decreasing your sugar intake in general is going to be better for people's health, and is certainly going to help weight loss. And I think to a lesser extent, but similarly, I think processed food in general is not helping us. It's not helping our health. It's not helping our weight. And we really have to, these highly processed, highly palatable foods are really not good for us in general. So that's something, that runs through everything that I teach patients, is really, we got to work on getting, decreasing that taste for sweet stuff. And we really have to get off some of this processed food. And that being said, then I think, for my patients, a lot of, especially my female patients, I think we eat inadequate protein. Yeah. And so one of the key things that I really work on with my patients is let's get in adequate protein. And sometimes let's not overdo it at a meal, right? Like you can have too much protein at a meal, you're not absorbing it, it's not doing you any good, but getting adequate protein, and then increasing vegetable intake, right? Lots of fresh vegetables, lots of different colors, because there's so much nutrition in it. There are phytonutrients in it, there's fiber in it. How we absorb and utilize our food really changes when we're eating more vegetables, and it feeds our microbiome in a way that's so important and essential. And so that's the other key thing is, we really got to increase the vegetables that we're eating. And I would say, when I was in primary care and I work with kids, I would always say to kids, do you eat your vegetables? No. And I'd say, can you name 5 vegetables you like to eat? And, kids kind of, carrots, they're thinking whatever, and they can't come up with 5 vegetables. So I send them away with their parents, and I say, every time mom goes shopping, I want you to pick one, or mom or dad, actually, I say, go shopping. I want you to pick one new vegetable you're willing to try. And then I give them a list of things that I think they'll probably like, right? So then I started, with adults, I used to say, tell me, is your nutrition good? How are you doing with your nutrition? And they say, oh, I do okay. I'm eating well. And so then I started to be more specific. And I said, are you eating 3 cups of vegetables a day?
Yeah.
Which is a very different question from are you
Right.
eating right? And
Right.
most patients are not eating 3 cups of vegetables a day.
Yeah.
So when you're very specific about that and you say, hey, what are you actually doing? They're like, no, and then I can ask my adults, can you name 5 vegetables you like to eat? And unfortunately, there's lots of adults who can't. So, it's like, wow, we need to work on that. And so, so increasing vegetables for all of those things that I described, getting adequate protein, and then let's really cut back on processed food, on sugar. And I think in general, you're going to feel better. You're going to be healthier, regardless of where your weight is, making those kinds of changes.
Yeah, absolutely. I totally agree with everything you say. And, back to changing the way you ask a question, because, you can say, do you eat healthy? Or, someone can say, oh, I eat a really healthy diet, but everybody has a different idea of what healthy means.
Yes.
Right.
Yes.
And so, like you say, changing the way you ask the question to really identify, not, are you eating something that you think is healthy? Let's talk about exactly what are you eating, and, talk about whether or not it contains the components that are necessary for you to have optimal health. So,
yes, no, I think that's exactly right. And I would say too, for like your students, even just a 24-hour diet recall is so helpful and pretty quick to kind of get a picture of what people are doing. So I'll say, I either will say, what did you have for breakfast, lunch, dinner yesterday? Or I'll say, what do you normally eat for breakfast? And people will tell me, what do you eat for lunch? What do you eat for dinner? What kinds of things do you snack on? What kinds of things do you like to drink? And then you get this much more rounded picture of what's actually happening, than just the very simple, how, and obviously a dietitian's going to get those details anyway. But I think for physicians in particular, it actually doesn't take that long, and you get some really interesting, good information. And so patients who are like, oh, I'm exhausted all the time, my reflex is terrible, whatever. And you just do this really quick, well, just tell me, what do you have for breakfast, lunch? And suddenly it's like, oh, it's just really surprising. So I had a patient, for example, which is interesting, that she was coming in just, oh, I'm tired all the time. I don't feel good. It's really tough. I don't know what's going on. And I said, what do you eat? Tell me what you eat. What do you have for breakfast? Well, I don't usually eat breakfast. Sometimes I'll have coffee. What do you have for lunch? Well, I don't usually eat lunch. Like, okay. And what are you eating? And so she was eating a Twinkie around 2 or 3 o'clock in the afternoon, and then would have something for dinner, and she would have coffee in the morning. That's all she was eating. And I thought, so she didn't carry extra weight, but I'll tell you, she was not healthy. Right. And I said, I think your fatigue is from what you're eating. And she said, really? Do you really think so, Dr. Abby? I was like, yes, I really do. I really do.
Oh,
so,
gosh.
Really helpful to just very quickly say, tell me what you're eating.
Yeah.
And wow, all of a sudden it's like, I think I know what your problem is. I think I can help you. Yeah. Yeah.
Yeah. Well, that's awesome. So, well, this has been a really fun conversation. We have gone to a lot of different areas. You have clarified many things for me, which I appreciate. So thank you. And also I want to thank you for being a huge supporter of NTI and having one of our grads on your staff, as well as just being an advocate for eating well and having a nutrient dense diet overall, because of course that is our goal as well. That's the message we want everybody to get, is about making better choices to improve the nutrient density of your diet. So,
and it's such good work, right? I mean, I think it's so crucial to our health. So I think it's fabulous what you're doing, and I love having my NTI grad.
Well, thank you.
She's just remarkable, but she really, that functional nutrition piece and that sort of holistic approach that you guys teach, it really is a nice adjunct to helping people, get and stay healthy. So it really is, it's good information, and I think it is going along with the current science. science. This is
Yeah.
really what we understand is happening. And it helps my patients live better. So yeah.
Yeah. Well, thank you for that unsolicited testimonial for our curriculum. So thank you. I appreciate that. I want to give you the opportunity to tell people how to find out about you and your clinic and, the ways you make a difference in the world. So tell us about how they can contact you.
Yeah, thank you. So if you go online to my website, it's Healthful Life MD, and healthfullifemd.com. So you can find us there. And if you have questions for me, please feel free to reach out or give us a call, and I'm happy to call you back or curbside or whatever, if there are practitioners out there who have some questions for me. But also if you have patients who would benefit from what we do and that really comprehensive approach, or patients who have more medical complications associated with, with obesity and with their health, then I would love to see them. And so you're welcome to refer the patients directly if you wanted to call, or if you send them to the website, they can actually just sign up to have a phone consultation with me. And I actually do free phone consultations with patients, so they get an idea of, who I am, what we do, what to expect, and just see if it's a good fit, because I know a lot of patients who are struggling with their weight have had some negative interactions with physicians, or not so positive interactions, at least. And it may be hard for them to even think about approaching a physician. And so if you have patients who you think would benefit from what we do, I'm happy to talk with them. And I do provide that free phone consultation to help them understand where I'm coming from and just see if it's a good fit for them. So That's awesome. Just at the website, Healthful Life MD. And like I said, feel free to, they can feel free to give me a call if they just want to curbside me on something, or any questions as well. So I'm happy to support you that way.
And do you do any kind of social media, Instagram, that kind of stuff?
So we're not super active on it. We do have an Instagram account, and we're not doing a ton of it. So you can find some old stuff there. We have blogs and newsletters on the website. And so we do have that kind of information. There's a physician facing website, and we're going to have more kind of scientific article based things on that. And so I think your audience today would enjoy looking at some of those things. And that's going to run the gamut of things like medications and current research, nutrition, exercise kind of science. And so some of the newer stuff coming out, so that they can, better understand it and sort of see what's going on in that world as well. So
great. Very good. Yeah. All right. Well, thank you so much for your input today. Thank you so much for your experience and your, just your depth of knowledge in this subject. So it's been wonderful talking to you, and have a great, wonderful rest of your day.
Thank you. Thank you so much for having me. You as well. Take care.
All right. Thanks. Bye. Hi there, and thanks for listening today. If what you heard today inspires you to want to pursue an education in holistic nutrition here at Nutrition Therapy Institute, please check us out on our website, ntischool.com, and reach out to us at admissions@ntischool.com. Our in-depth, comprehensive education is sure to provide you with the knowledge and skills you need to create the work of your dreams. Do something that feeds your passion, aligns with your values, and fuels your drive for a vital and meaningful life. It will be rewarding for yourself, your family, and anyone else with whom you interact. And with that, see you on the next episode.